friends. I'm Dr. Evraj Chandalia, Director of Endocrinology Diabetes at Just Look Hospital and my own center, Diabetes Endocrine Nutrition Management Research Center. I'll speak to you today about how you minimize hypoglycemia while using insulin. You know that insulin is a great tool and you must use it whenever required. Without that, you cannot produce good metabolic control in a long-standing type 2 diabetic. So there is a lot of hypoglycemia with insulin which deters you from its use. And as you see here, the main agents which cause hypoglycemia in diabetes are sulfonylureas and insulin. Insulin even 3 times that of even sulfonylurea. So how to skirt around this issue of hypoglycemia is the key to success in insulin therapy. Hypoglycemia is a barrier to insulin therapy. We know that hypoglycemia can be dangerous. Most importantly, hypoglycemia causes weight gain because patients can indulge into defensive eating. Although we have shown that this part of this weight gain really is the weight lost prior to instituting insulin therapy. Sometimes the side effects of hypoglycemia are very serious. For example, it can lead to an accident, lead to coma, convulsions, and recurrent hypoglycemia can lead to some cognitive defect. Whenever we use any intensive therapy to control diabetes, we are faced with the problem of hypoglycemia, as is evident in these 3 studies, which are often quoted together, that is ACCORD, ADVANCE, and VADT, where intensive group suffered from about 3 times more hypoglycemia than the standard therapy group. ACCORD study also showed something very interesting, that if you achieve a very rapid control of diabetes producing recurrent hypoglycemia, there can be increased cardiovascular mortality. And this in fact made the investigators of this study to modify the study and some passages of the study. So what we learned from this is the early stage of type 2 diabetes, control the diabetes very strictly because this will derive maximum benefits in the long run. But the later phase is you must relax your A1C and blood sugar goals, and it doesn't have to be 7 as is standard, but it can be 7.5 or even 8. Let us first look at the causes of distressing hypoglycemia with insulin therapy. The first cause is inappropriate insulin doses, which are not physiological. So you have to mimic normal physiology, like a higher dose of short-acting insulin at breakfast, little less at lunch, intermediate between dinner, and almost about half of the insulin for the basal requirement. If the patient is not rotating the insulin injection site, then there is hypertrophy or lipoatrophy, and that introduces variability of insulin response. It is advisable to use multiple small doses of insulin in order to minimize hypoglycemia. You should also know that incidence of hypoglycemia is much less with long-acting basal insulins as compared to prandial short-acting insulins, and as therefore always use adequate doses of basal insulin, which should be about 40 to 50% of the total dose. It is also important to know that the coefficient of variation of insulin responses is quite variable between different insulins. The short-acting insulins again have less variability, while the variability is a lot more in the long-acting insulins. Insulin pumps reduce the variability of insulin response considerably. For example, the variability of response is 10 to about 50% in different insulins, with insulin pump which only uses the short-acting insulin and delivers it properly physiologically. The variability comes to as low as 3%. Another strategy is to use insulin sensitizing agents along with insulin therapy. For example, metformin, pioglitazone, and for that matter, any other agents like SGLT2 inhibitor or DPP4 inhibitor, they all reduce the insulin dose. And once the dose is reduced and divided into multiple small doses, hypoglycemia is reduced considerably. When you use a sensitizer, try to use ones which do not promote hypoglycemia. So do not use sulfonylureas or glinides as much as possible. However, they are superb sensitizers, and at that time you can use them but very, very cautious. When you are facing with recurrent hypoglycemia, it is important to revise your A1C goal. For example, long-standing diabetic with complication, instead of targeting 7 or 6.5 A1C, you should revise it to 7.5 or 8%. As we have the continuous glucose monitoring system available with a lot of hypoglycemia, put up the sensor for about 2 weeks and correlate the data of blood glucose with the meal and activity, and you'll get tremendous insight into the genesis of hypoglycemia in a given patient and rectifying it accordingly. Keep in mind the possibility of hypoglycemia because of drug interactions. For example, alcohol of course is more notorious for promoting hypoglycemia, as well as some of the drugs like sulfonylurea, antimalarials can cause hypoglycemia. Most important thing in our country, of course, is gastrointestinal upset, which can cause bad hypoglycemia, and patients should be taught the 6-day routine when you are starting insulin therapy. So how do we minimize hypoglycemia in insulin therapy? First of all, we may have to revise our A1C or blood glucose goals. Secondly, we have to educate the patient on the interaction of food, activity, and insulin thoroughly. Tailor your insulin doses properly as far as the normal physiology is concerned. Use insulins which are of better quality, which have less coefficient of variation day to day. And of course, always use a sensitizing agent in type 2 diabetic when using insulin therapy. So all these maneuvers will lead to the very lower incidence of hypoglycemia with insulin therapy. There are some special situations causing hypoglycemia in insulin therapy, and one is nocturnal hypoglycemia, which is very distressing. How to avoid that? One is, of course, one maneuver is to use a short-acting analog at the dinner time, because use of human regular insulin may be prolonged and more likely to cause hypoglycemia. And sometimes we also shift the basal insulin, which is normally given at bedtime, we shift it to morning time or some other fixed time during the day. Threshold for hypoglycemia varies with age, and in elderly people, the gap between the sympathomimetic discharge symptoms with hypoglycemia and neuroglycopenia where they pass out is very narrow, and therefore they can suddenly go into unconscious state, and you have to be fully aware of this when using insulin in elderly people. There are certain groups of people who are more prone to hypoglycemia, and they have impaired perception of hypoglycemia. So impaired awareness of hypoglycemia occurs in very tightly controlled people, diabetics of long standing, and sometimes the elderly people. And therefore, you have to be again exercise extra precaution. You may have to lower your insulin doses. You may have to revise your A1C goal upward in order to avoid recurrent hypoglycemia. I would like to recapitulate for you some of the key points of this talk. One is that the sulfonylureas glycinates can aggravate, and insulin of course can cause hypoglycemia. So when you are using sensitizing agents in insulin therapy, please use drugs which do not cause much hypoglycemia, like DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1s. Secondly, remember that hypoglycemia is detrimental to health. It is now proven that recurrent hypoglycemia can promote even cardiovascular episodes, so you must avoid it at any cost. Other key points in avoiding hypoglycemia are that you should make a good dose plan in your patient, which is quite physiological. Use analogs when required, especially in nocturnal hypoglycemia. Use adequate doses of basal insulin, and use insulin with less coefficient of variation, which means shorter acting should be used more often. A few precautions. Nocturnal hypoglycemia must be avoided at any cost because the counter-regulatory responses also in the reclining position are inadequate or slow. Secondly, the elderly people be very careful, as I pointed out, and be aware of patients who have hypoglycemia unawareness, and you may have to revise your A1C goals there. Thank you for listening to this talk. Our next episode will be on sweetener, and talk will be delivered by Sonal Chandalia.